Yeah. So thank you very much, Adina, for the introduction, and thank you, Christina, for this very insightful presentation. I'm looking forward to meet you in person in Israel in about 3 weeks. Um, and thank you, Dr. Oksana, for inviting me to talk about chronic migraine, which causes a major headache for most headache specialists. And in this presentation, we'll discuss about the management of patients with chronic migraine, which means how to choose the right acute and prophylactic therapy while trying to limit the use of acute headache medications that have been said associated with medication overuse headache. These are my disclosures. And migraine is, we all know, it's very common, and the prevalence is about 15%. In some countries, it's even higher, more in women, and it is ranked as the second most disabling disease amongst all diseases globally in terms of years lost due to disability, and it is associated with significant morbidity and considerable negative impact on quality of life. And we all know what migraine is: recurrent headache attacks that last 4 to 72 hours, typically a unilateral location, pulsating quality, moderate to severe pain intensity, and sometimes it's aggravated by physical activity, and that the most common associated symptoms are photophobia, phonophobia, nausea, and vomiting, which are usually defined as the most bothersome symptoms. Chronic migraine is defined as more than 15 headache days per month for more than 3 months, and a fulfillment of ICHD-3 criteria for migraine on more than 8 days per month. So, some of the migraine patients use abortive drugs to relieve pain, and their life goes on. But in some patients, because of frequency, more than 4 monthly headache days, severity and impact on quality of life, or adverse event with acute treatment, a preventive treatment is required. So basically, the main goals of preventive treatments are first to reduce attack frequency, severity, and the duration, to improve the responsiveness to treatment of acute attacks, to improve function and to reduce disability, and to prevent progression or transformation of episodic migraine to chronic migraine. And based on the level of evidence for efficacy, we have oral treatments that have established efficacy for migraine prevention, the anti-epileptic drugs, the valproic sodium, the topiramate. We have the beta blockers, metoprolol, propranolol, timolol. We have the fluvotriptan for short-term preventive treatment of menstrual migraine. And we have parental treatments such as Botox and CGRP monoclonal antibodies. In the probable effective group, we have the amitriptyline, the venlafaxine, and certain beta blockers, and memantine, which we rarely use. I don't know why amitriptyline is probably effective, as I can say from my personal experience that it's as effective as the drugs in the established efficacy group, if not more, but this is how it is. Now, how do we choose the right treatment? So in patients with hypertension who are non-smokers and younger than 60 years old, reasonable options include the beta blockers, metoprolol, propranolol, or timolol, of course, in the absence of contraindications to beta blockers. But in patients with hypertension who are smokers or are older than 60 years old of age, beta blockers should be avoided because they may be associated with higher rate of stroke and other cardiovascular events compared with the other hyperintensive drugs such as verapamil or flunarizine. For patients with depression or mood disorders, reasonable option include amitriptyline, venlafaxine, and we will try to avoid in these patients topiramate, which may worsen anxiety and depression. For patients with epilepsy, of course, the reasonable options include valproic or topiramate. For patients with insomnia, we'll choose amitriptyline. For patients with obesity or with high intracranial pressure, topiramate is a reasonable option. And a very important tip, opioids should not be used for the acute or preventive treatment of migraine. Opioid use can contribute to the development of chronic daily headache and can interfere with other preventive therapies. If there is no response to treatment after 8 weeks at an optimal therapeutic dose, of course, we usually switch to a different preventive medication, either in the same class or different class. But unfortunately, we know that 50% responder rate for most of the oral preventive medications is only 45%. In other words, only 45 of people will have a 50% and more decrease in migraine headache days a month. And we must wait at least 4 to 6 weeks on an optimal dose after titration to get any relief. So we have many problems. We have a problem of efficacy, a problem of lack of specificity, because these drugs were not developed initially for migraine. We have adverse events and mostly a problem of adherence, as we know that 83% are off this medication in 1 year. We also have comorbidities that limit the possibility of using oral prophylactic drugs in some patients. As for now, there are 5, I call it injectable preventive therapies for migraine: botulinum toxin, Botox, 3 monoclonal antibodies targeting calcitonin gene-related peptide, the CGRP, the fremanezumab, the galcanezumab, and the actinezumab, and 1 targeting the CGRP receptor, erenumab. Botulinum toxin A, Botox, is approved for chronic migraine, and erenumab, fremanezumab, and galcanezumab are approved for episodic as well as chronic migraine. The major advantages that all the injectable preventive therapies have in common is that there is no need for gradual dose titration, relatively rapid onset of actions within days, a week, or 2 weeks, and a great tolerability and adherence. What are the indications for initiating treatment with monoclonal antibodies to CGRP peptide or its receptor, according to the American Headache Society positioning statement and the European Headache Federation guideline from 2018, because these are the latest guidelines that we have for the treatment of chronic migraine. And it actually reflects what we usually do for the past 3 years since these drugs were approved by the FDA and other health authorities. So patients with low frequency episodic migraine with 4 to 7 monthly headache days must have both of the following: inability to tolerate due to side effects, or inadequate response to a 6-week trial of at least 2 oral preventive drugs and at least moderate disability, MIDA score more than 11, HEAT6 score more than 15. Patients with high frequency episodic migraine with 8 to 14 monthly headache days only have to prove inability to tolerate due to side effect or inadequate response to at least 2 oral preventive drugs, no functional disability. They could have functional disability, they probably have, but they don't have to prove it. Patients with chronic migraine must demonstrate either inability to tolerate due to side effects or inadequate response to at least 2 oral preventive drugs, or intolerability or inadequate response to Botox. How do we define a success of these or biologic treatments, the monoclonal antibodies to CGRP? So we must have, we must show 3 months of outcome data for patients receiving these treatments, using a headache diary that shows a reduction of at least 50% in headache days compared to their situation before starting the treatment, or clinically meaningful improvement in MIDAS or HEAT6, which estimate functional disability with regard to work and to home and social life. In patients with chronic migraine, we asked if preventive treatment with CGRP monoclonal antibodies as compared to placebo effective and safe. So we already know that based on clinical trials and real-world data from all over the world, all the 4 monoclonal antibodies were found effective and safe for the prevention of episodic migraine and chronic migraine. How effective? It seems that all the monoclonal antibodies decreases headache days per month, 1.5 to 3 days per month more than placebo. And another way to look at it is that about 40% of chronic patients achieved more than 50% reduction in monthly headache, in monthly migraine days from baseline to week 12, which means that the 50% responder rate of, for example, from anezumab in chronic migraine, it's quite similar to what we have seen with all the other drugs, is about 40%. Hundreds of trials from around the world in a real-world setting showed even much greater efficacy and no change in the safety profile that were demonstrated in the randomized controlled trials. And based on this excellent efficacy and safety that were demonstrated over 7 years now, 3 years since they're approved by the FDA, and 4 years since they're approved by the FDA, and 3 more years of research, the European Headache Federation has published an update to its guidelines on the Journal of Headache and Pain very recently, a few months ago, that there are actually no reason on clinical grounds to postpone the initiation of these treatments, and that postponing the initiation of CGRP monoclonal antibodies may favor disease progression and chronicity. And they suggested that in individuals with migraine who require preventive treatment, monoclonal antibodies targeting the CGRP pathway should be included as a first-line treatment option. How should other preventive treatments, mainly oral preventive treatment, be managed when using CGRP monoclonal antibodies in patients with migraine? The EHF recommendation, European Headache Federation, recommend stopping oral preventives before initiating CGRP monoclonal antibodies in episodic migraine But in chronic migraine patients, we should not stop. We should add CGRP monoclonal antibodies to oral preventives and then assess the need for withdrawal. Regarding to Botox, Botox should be stopped anyway prior to use of CGRP monoclonal antibodies, according to the guideline. And the reason for that is that in the randomized clinical trials, treatment with Botox was not allowed. And the other issue is, user is requesting remote control of your screen. You can regain control at any time. Okay, approve, whatever. And the reason for this, treatment with Botox was not allowed in the randomized control trial. And the other issue is that both drugs, the biologic drugs and Botox, are very expensive. But we know now, based on some reports, that's the combination of treatment with Botox with the CGRP MABs might even offer a synergistic effect or benefit. So in many headache centers, mainly in the US, I think that in Europe as well, they actually do both treatment with Botox and CGRP monoclonal antibodies. The AHS points out that the risk of drug to monoclonal antibodies interactions is minimal because the mechanism is quite specific. And they suggest adding CGRP monoclonal antibody to the existing regimen and assess efficacy before making further changes. But many physicians, including myself, don't like polypharmacy in chronic migraine patients, and specifically those who consume lots of acute medications and are diagnosed with medication overuse headache. On the other hand, we now have evidence from topiramate, Botox, and monoclonal antibodies studies that medication overuse declines and patients get better even without withdrawing them from acute medications. And that's what I do. I don't withdraw my patients from medications, acute medications, before I start with CGRP monoclonal antibodies. Erenumab, for example, reduced migraine frequency and acute medication treatment days in patients with chronic migraine and medication overuse headache, and improved disability and quality of life. When should treatment with monoclonal antibodies be stopped in patients with migraine? Because these drugs are very expensive. So according to the AHS, American Headache Society positioning paper, benefits of CGRP monoclonal antibodies should be assessed after 3 months, and we have to prove a reduction of at least 50% in headache days compared to baseline, or we have to show clinically meaningful improvement in MIDAS or HEAT-6. According to the European Headache Federation, we should consider monoclonal antibodies discontinuation after 6 to 12 months because there is evidence that sometimes we get a benefit only after 6 months of treatment. Should overuse medication be withdrawn before offering CGRP monoclonal antibodies to patients with chronic migraine? We discussed about this. Both the American Headache Society and the European Headache Federation agree that CGRP monoclonal antibodies can be used before or after the withdrawal of acute medications, as we discussed before. In patients, in which patients should CGRP monoclonal antibodies not be used? So it is not recommended to use these drugs in pregnant or nursing women because safety was not tested yet. In patients with alcohol or drug abusers, we must be very cautious in patients with cerebral or cardiovascular disease. And having said that, I'm aware of the research that has been done in erenumab, with erenumab in patients with angina pectoris, but we still have to be very cautious because we know that CGRP inhibitors actually they inhibit the vasodilation of blood vessels, and that may lead to vasoconstriction. So it's theoretically, but we still have to be cautious. And all of these contraindications are based on the exclusion criteria of the randomized controlled trial rather than real evidence data. What should we do for partial responders? So the EHF has suggested to add an oral preventive medication, and the American Headache Society doesn't have any recommendation. What are the options? So the options are to add preventive oral medication or switch to a different monoclonal antibody if we want to avoid polypharmacy. And we have some evidence now that switching between MABs, even between ligand MAB and to a different ligand MAB, may lead to a totally different response. And we also experience this in our practice. Sometimes I give a certain monoclonal antibodies to a patient. There is no response at all, but when I switch to a different monoclonal antibody, I get even headaches-free. So we know that, for example, we have experience with treatments, and we know that patients who respond to one treatment may not respond at all to a different treatment, and we think that the same management should be adopted with CGRP monoclonal antibodies. Now we'll talk about acute treatment. I started my discussion talking about the preventive treatments, which are most important in the management of chronic migraine. But of course, we have to discuss about acute treatments as well, because patients with migraine who consume these acute treatments should be managed as well. And the goals of the acute treatments of patients include, if I had to develop an acute or abortive treatment, the goals would be rapid and consistent freedom from pain and freedom from associated symptoms, especially the most bothersome symptoms, without recurrence. To restore ability to function as fast as we can, to minimize the need for repeat dosing or rescue medications, to get an optimal self-care. The patients must feel that he controls the disease and not the opposite. The disease controls him. And to reduce the subsequent use of resources, such as emergency room visits, diagnostic imaging, ambulatory infusion center, and etc. And we hope that we won't get any side effects or minimal side effects. And of course, we have the cost considerations, because some of these acute treatments are quite expensive. These are the acute treatments with evidence of efficacy in migraine. We have the non-steroidal anti-inflammatory drugs, NSAIDs. We have the non-opioid analgesic, the acetaminophen, or caffeinated analgesic combinations such as aspirin, acetaminophen, and caffeine. And we give these drugs for mild to moderate attacks. And we have migraine-specific agents such as triptans, DHA, and a small molecule CGRP receptor antagonist, the Japans. We have the selective serotonin 5-HT1F receptor, the ditans, that we're going to talk about these drugs specifically in the next slides. But I'm sure that we all know the adverse events that may come up with each of these drugs. NSAIDs can cause serious gastrointestinal, intestinal, and cardiovascular side effects. Triptans and ergot should be avoided or used with caution in patients with coronary artery disease, peripheral vascular disease, in uncontrolled hypertension, and other vascular risk factors. And we have evidence that should suggest that about 30% of patients who were treated with triptans have an insufficient response or a rebound headache. And some patients say that triptans stop their headaches, but make them exhausted and not functional after taking them. So we have two major issues: contraindication to coronary heart disease, cardiovascular disease, and rebound/medication overuse headache. Patients with migraine who need to use acute treatments on a regular basis should be instructed to limit medication use to an average of 2 headache days per month, 2 headache days per week, or up to 9 days per month. And patients who exceed this limit should be offered a preventive treatment. Patients who continue to overuse acute medications while receiving preventive therapy may require a higher dose of preventive medication or adding a second preventive treatment in these patients. We know that medication overuse headache has been found to make headaches less responsive to acute medications, as well as less responsive to preventive treatments for migraine. The newer medications, by the way, the CGRP receptor antagonists and the neuromodulations that we're going to talk about it in the next slides, do not appear to be associated with medication overuse headache, and we'll discuss about this shortly. So the FDA has recently approved or cleared 5 therapies, acute therapies for migraine: the celecoxib, the lasmidatan, the remote electrical neurostimulation, or Nerivio, the rimagepant, and the ubrogepant. We all know the celecoxib, which has been used to treat acute pain since 1998 and is approved now for the acute treatment of migraine. It's an oral solution, and as with other non-steroidal anti-inflammatory drugs, it carries a box warning about the risk of serious cardiovascular thrombotic event, myocardial infarction, and stroke, and is contraindicated in the setting of coronary artery bypass graft surgery. Other safety concerns with celecoxib include an elevated risk of spontaneous bleeding, ulceration and perforation of stomach or intestine, particularly among elderly patients. We have to be very careful, and those with a history of peptic ulcer disease and gastrointestinal bleeding. Lasmiditan is a diton that activates the 5-HT1F receptor, as opposed to 1B and 1D receptors with the older triptan, the elatriptan, the rizatriptan, etc. The most common adverse event of these drugs were dizziness, fatigue, paresthesia, sedation, nausea, and vomiting, and muscle weakness. And lasmiditan has been associated with driving impairment and sleepiness. So patients given a prescription for lasmiditan should be cautioned not to drive within 8 hours after taking their medications. And also, since it's a kind of triptan, it may potentially cause medication overuse headache, as with the older triptans. Lasmiditan was approved as effective as triptans based on positive results from 2 randomized controlled trials, clinical trials, that were evaluating lasmiditan doses of 50, 110, and 200 milligrams. Ubrogepant, Ubrelvy, the first drug in the Japan class to receive FDA approval for the acute treatment of migraine, has shown efficacy in 2 doses, 50 milligrams and 100 milligrams in randomized controlled trials, with an excellent safety and tolerability, as with all the CGRP monoclonal antibodies drugs. What is a Japan? It is a small CGRP molecule receptor antagonist. The most common adverse event were nausea, somnolence, and dry mouth, but in very small percentage of the patients. There was no evidence of medication overuse headache or a rebound headache, which is very important. There was no evidence of hepatotoxicity, like with the drugs that were developed before for the abortive treatment of migraine. And the half-life is only 5 to 7 hours, which is great, because after 2 days or 3 days, there is no medications in the blood anymore. Pain freedom in 2 hours was achieved in 21% of patients who were treated with the 100 milligrams, and 37% of patients achieved most bothersome symptom freedom. And the most bothersome symptom freedom, I remind you, is nausea, vomiting, photophobia, and photophobia. And 37% of these patients were most bothersome symptoms freedom in 2 hours. The Rimagepant, the Nurtec ODT, has demonstrated efficacy and tolerability that was quite similar to Ubrelvy, but has a longer life, a longer half-life of 11 hours, and thus is also indicated for prevention in episodic migraine patients, and not only for acute abortive treatment. So in one tablet, we get abortive treatment and preventive treatment. Rimagepant, like Ubrelvy and lasmiditan, does not constrict blood vessels and may have a role in patients with cardiovascular contraindications to treatment. And repeated acute treatment with Rimagepant does not appear to be associated with medication overuse headache and rebound, which makes it similar to Ubrelvy and may distinguish it from lasmiditan, who may cause medication overuse headache. We can also see in this slide that pain freedom was increasing over time from baseline in up to 56% of patients within 8 hours. This is very important. Nerivio is a remote neuromodulation device that was developed in Israel, actually very close to where I live. We put it on the arm, and it stimulates the arm with electricity, in various amplitudes and various frequencies. It achieved therapeutic effects by delivering this transcutaneous electrical stimulation, which induces conditioned pain modulation that activates a descending endogenous analgesia. It was approved by the FDA for the acute treatment of migraine and in adults based on the positive results in randomized controlled trial. It was cleared for the acute treatment of migraine and chronic migraine in patients over 12 years old and older patients, based on data from an open label single-arm multi-center studies. As with many non-drug therapeutic options, Nerivio has shown good tolerability and safety in clinical trials. Only paresthesia in the arm of the device. This was the most common side effects, and pain freedom was achieved in 37% of the patients after 2 hours versus 18% in a control group. And Nerivio may also reduce the use of medications and the risk for medication-induced headache. And finally, I would like to invite you all to the headache conference that I'm organizing in Tel Aviv every year. Professor Cristina Tassoleri and Professor Said Ashina, who are also speakers in this conference, are going to be there. Also, Professor Masoud Ashina, the past president of the International Headache Society, Professor Rami Burstein from Harvard, Professor of Neuroscience in Harvard Medical School, Professor Alan Rappaport, past president of the International Headache Society from UCLA, Professor Alexander Maskop, who is the director of the New York Headache Center, Professor Patricia Pozzo, who is a professor of neurology in Spain, in Barcelona, and Professor Piero Barbanti, who is a professor of neurology from Rome. And this conference is endorsed by the International Headache Society as well, and I invite you all to join us and to meet in person. Thank you very much.